Good evening, everybody. Today is Tuesday, October 25th, 2022. Today is a case list defense webinar. We'll be going to 10 o'clock tonight. With a raise of hand, I just want to make sure the audio is working properly. You can raise your hand. Okay, perfect. Thank you so much. Just to give fairness to everybody that has not been on the hot seat, if those have been on the hot seat for the last 2 or 3 webinars, if you can keep your hands down for the time being so we can get more people on the hot seat. If nobody is raising their hands, and we'll open it up to everybody on the call. So if you have not been on the hot seat for the last 2 or 3 sessions, please raise your hand. Okay, I'm going in your direction. Lee.
Hi, can you hear me?
Yes, how are you doing?
Perfect, good, how are you?
Excellent. Are you a generalist or a subspecialist?
Generalist.
Generalist. Do you want to go over a specific case on your list? You want a topic? What are you looking for?
Any case on a list. I guess I've done a couple mocks already, but so we'll go with GYN because I haven't done that yet with anyone.
Yeah, GYN. Okay.
Yeah.
Cool. All right.
I sent my cases in a couple nights ago, so hopefully they're.
Okay. Hopefully we can get those. Hopefully they're there. Yep, it's here.
Perfect.
GYN. Okay. So no specific cases worrying you?
Not off the top of my head just yet.
Okay.
And I'm taking my exam in the first week of December.
Okay, so you have some time.
Uh-huh.
All right, cool.
So I guess if there's anything that catches your eye.
Yeah, that's what I'm looking. I'm looking. So I'm going to be asking you about case 15. I'm just making it a little bit bigger here.
15. Okay.
And you should see the screen now. Not yet? You
I
see the
see
screen
it.
now?
Yep.
Excellent. So can you tell me what are contraindications to uterine artery embolization?
Active malignancy, hemodynamic instability, unable to access, inability for the radiologist to access her vasculature, pregnancy, of course. I'm sure there's a handful of others that I'm not remembering.
And can you discuss, after she's had all this treatment, like how did you discuss her continued treatment option counseling, for lack of a better word? Because I see she's tried multiple things. How did you discuss what the next steps would be, and how did you do that shared decision making with the patient?
Sure. So, so this patient basically obviously had fibroids and bleeding, and despite having had several rounds of medical management, as well as a DNC to try and take out any kind of fibroid that was abutting the cavity, she was still bleeding, and of course, uterine fibroid embolization. Failing that as well, then the next thing I would discuss would be, okay, you're being treated, but of course the bleeding is still there. Do you think that you would want definitive management? So if they understand that definitive management would make it so that they wouldn't have any bleeding anymore, but the downside would be that, of course, it is major surgery. They're not going to have they're not going to be able to have children on their own anymore, and potentially they would have risks of complications from the surgery.
What would complications be?
So since we did an LAVH, you have complications of entry. Actually, let me back up real quick. So with any surgery of risk of like bleeding and infection, you have complications of the entry, like I was talking about. So we entered Hassan.
Can I interject for a
Sure.
second here? How did you decide to proceed with that mode of hysterectomy? Can you go through your decision-making process? Because it was a good-sized uterus.
Sure. So it's one of those things that my partner and I will actually operate together. And so given that that I train doing TLHs actually, but she's also much more comfortable with vaginal hysterectomies, and I am also wanting to get more exposure to vaginal hysterectomies than the number I needed to graduate from residency. We decided to go in that direction to do the LAVH.
And in your evaluation, how did you know she'd be a good candidate for an LAVH?
On exam, even though her uterus is a little larger, we knew that it was mobile. She had 3 children before, all, I believe, vaginally, so we knew that her pelvis was adequate. Yeah.
Anything else that persuaded you to do the LAVH, just on your exam or the patient in general?
Not that I can think of right now.
Now, during the case, at what point did you terminate the laparoscopic portion of the procedure and then continue it vaginally?
We dissected down to the down to just above the cardinal ligaments in the uterine artery, and then went down below at that point.
So you got the uterines laparoscopically or for vaginally?
Vaginally.
Okay. Now, was there any issues in removing the uterus vaginally? Did you have to
Do we have to more? Yeah, I would have to look at the op note. I don't remember.
Let's say you had to.
Sure.
What would be some of your concerns?
Sure. So with the size and with fibroids, I would have concern that it would not deliver easily through the vagina. So I would have to figure out how do I get this out. There's several options to doing that. We could either kind of bivalve the uterus and deliver half of it at a time. We could, and while we do that, we could also do myomectomy, so to speak, and take out any large fibroids that would contribute to its volume. And just kind of carefully do like a, trying to remember the word, but excise it in a continuous strip.
Now, were you concerned in the process of, breaking the specimen into pieces that there'd be an issue with seeding anything? And if you were, did you do anything? Can you do anything to prevent that?
Sure. So in this case, we had a prior. We know that she had fibroids. There wasn't something that was rapidly enlarging. We had done a DNC before, so we had sampling from the endometrium. So overall, very low risk of having some sort of uterine malignancy present. But if we were concerned, it is possible to place it in a bag I don't remember the specific brands, but I think there's bags that do have larger rings on the end that we could place the uterus in and just kind of have the ring on the outside of the vagina and morcellate it at that point.
So let me interject here. You said that you
Mhm.
entered through the htan technique. What was the decision to do that?
That's something that me and my partner are both comfortable with. Basically, we know that all the different entry methods all do have pretty similar risks, and one is not better than the other. But this is one that we've done, that I did many times in residency, and she has also done throughout her career as well.
And what was the size? And I see it was 430 grams. What was the uterine side on exam?
I would need to check my op note.
Was it like 16 weeks?
Yeah, I'd probably say around 16, 14 to 16. Yeah,
And you entered at the umbilicus or elsewhere?
at the umbilicus.
And you weren't concerned that there might be an issue with visualization, seeing that the fundus was like right there, just a couple of centimeters from the umbilicus?
Yeah, I see what you're saying. That's always a possibility, but once we place that trocar, if we did need to place any other trocars to have better visualization from higher up in the abdomen, then we would have been able to do that.
And where would you have gone if you were going to have
Um,
difficulty in the umbilicus?
we could have gone to Palmer's Point.
Where's Palmer's Point?
It's in the left midclavicular line, about 3 centimeters below the costal margin.
And how would you have entered there? Would you have done htan as well or something else?
Would have done probably direct optical.
So like with an OptiView?
Yes.
And what type of energy source do you use during your laparoscopic case, or this case, for example?
We like to use I like to use the harmonic as well
And
as bipolar if needed.
okay, and what does the harmonic scalpel? What is its energy source?
I would need to get back to you on that.
All right, let's stop there. What did
Okay.
you think? It's
The counseling question threw me.
really? Why?
Well, just I
It
know
did?
that there was things that everything I'm fairly certain that everything I said was right, but I knew that there was things that were missing, and I like to be complete in my counseling. I don't like to leave anything, like anyone else. I don't like to
I
leave
mean,
anything
she
out.
tried a lot of stuff, IUD, the OCP,
Yeah,
she did a UAE. I mean, she did a lot. I mean, what else
yeah,
can you do? You
sure,
got
and
those
probably
new,
more. Uh,
yeah, go ahead.
I was just say probably I could. I always like to be more well spoken when I counsel too.
I think you did fine. I didn't
No,
see anything that was of concern. And I kept cutting you off, so apologies on
gotcha.
that because I'm
No
very
worries.
interested. It's a very good size uterus, so good
Hmm.
on you for doing LVH. The one critique I would say is don't degrade your talent by
Hmm.
saying, well, my partner is really good at TBHs, I'm good at TLHs, and just say, this is what we thought it would be best. We knew it might be a difficult case to be done vaginally, and we thought it'd be best to start the case from the top, and then, continue from the bottom, so to speak.
Gotcha. Yeah, that was one of the things I was gonna ask about, but came up. So yeah, and I was the one a couple nights ago asked about robot versus this on
Oh,
my
you got
list.
asked that?
Yeah.
Okay. And what did they tell you to guide your answer? I mean, I've had
Oh,
people tell me, I need to get certified with a robot, so that's why I did the case as a robot.
yeah.
And there's nothing wrong with that answer. I'm sorry, I didn't mean to interrupt you.
Oh, no worries. Mine is basically that, like I kind of implied, me and my partner do like to operate together, but if she's not
Right.
available, then it
For your
replaces the
assist.
field assistant.
Yeah, and I've heard that response as well. Which who can fault you on that,
Hmm.
right?
Yeah. Yeah.
Um, what else? What else? What else? Yeah, that would be my only technique. And you said like we a couple of times. It's really I.
Hmm.
I know you're doing the case together.
Sure.
But that's impressive. You're able to do a 430 gram. Um, uterus, and you went back. Well, I had a low suspicion. I do know I did a mock oral like last year, and they
Mhm.
actually seeded just the myoma everywhere. She got that
Uh,
peritonitis, and it was just, yeah. So that's rare, but it
yuck.
was
Yeah.
from the breaking down of the. I was like, what? That scared the heck out of me. There's a name for it. I'm blanking right now.
Mhm.
So, but yeah, I thought your answer of that was good. I mean, everything looked negative. She's 36 years old.
Mhm.
Um, that type of thing. Um, and something to think about, like what other options could you have done that was not a hysterectomy? Well, she's really not a candidate for an endometrial ablation. I mean, I guess you could do a hydrothermal, but that's a pretty big
Mhm.
uterus, but the
Yeah.
water can go all over the place. You have that newer technique where you put that probe laparoscopically into the fibroid and it crosses it, but
Mhm.
can you, is that a possibility? I'm sure there's not many studies. Don't say studies on the exam. After
Sure.
you have a UAE, is that going to be beneficial? And there's not
Yeah.
enough studies for sure. I mean, this is too
Mhm.
new of an entity to um,
To talk about that.
to
Now,
talk about that. Yeah,
if I were to bring up like I'm at a community hospital, and stuff like that is not even available as an
right.
afterthought. Um,
You could always, if they say the patient was extremely adamant not to have a hysterectomy, then you
mhm.
could say there's a newer technique. We don't have it here. We
Uh-huh.
can, send you to the big city, for lack of a better word. Hopefully, we can find a provider that takes care of that up there,
Gotcha.
down
Gotcha.
there,
Gotcha. And
wherever
there's always,
the big town is. It's kind of
yeah,
like VBAC. If you don't do VBACs or TOLACs in your community hospital, there's always some doc in, the town next door that you usually, send to in a timely fashion so they won't decline her care.
sure. Yeah,
Yeah.
exactly.
Any other questions?
Um, no, no,
And
thank you.
harmonic scalpel uses ultrasound.
Hmm.
So I don't know how to explain. The
Yeah,
blade goes really
it
quickly
goes
and it
back and
uses
forth. Yeah.
ultrasound. And
So
the
I
ultrasound,
had,
it makes that energy.
yeah, I had thought that you were at, um,
Yeah.
I knew that it's a high frequency, but I thought you were
Yeah.
asking like, what goes through the cord to make it,
Oh,
to
no,
make it
no,
do
no, no,
that.
no, no, no. That's a little bit too much physics, I think.
Gotcha.
But but you do have to have a little bit more of a technique if you use the harmonic versus the ligature.
Sure. Yeah. Yeah.
Because if you can't really cauterize for a long period of time. I mean, you get the stuff getting stuck to it. Sometimes you bleed. So there's a trick
Mhm.
to doing the harmonic compared to the ligature, for sure.
Sure. Yeah.
Yeah, I'm sure
Definitely.
you know what I'm talking about. Yeah. Any other questions? No, but nice job. It's an
Thank
interesting
you.
case. It's a big uterus. But that's the only critique I have is don't negate your skill set, so to speak.
Gotcha. 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 Thank you.
You want to be humble in the exam. You don't be cocky. You say,
Hmm.
definitely this could be. I mean, I'm sure there's somebody out there who could be able to do this vaginally, but it'd be a little bit difficult.
Yeah.
As you keep going up and up and up and up and up, and maybe she has a really wide um, fundus, depending on where the
Mhm.
fibroids are. So you can just start from that top and make sure you got the stuff you need on the top and continue on the bottom. And for
Yeah.
those on the call, the differentiation between the LAVH and the TLH is in an LAVH you get the uterines from below. So, just because some people have like they have a TLH on their list, but it's really a LAVH and vice versa. So that's the true technique or the definition, to my understanding. The key here is you were able to do it minimally invasive, so that's a good thing.
Hmm. Yep. No
Okay.
big
Any other
incisions.
questions?
Nope. Thank you.
All right. Good job. Yeah. All righty. So Ashley Nicole, I'm going in your direction. Says you're self-muted. There you are.
Hi,
Hi. How's it going?
it's going well. How are you?
We're hanging in there. All we can do, right?
Okay, that's right. I was
So
thinking maybe
go ahead.
I was thinking maybe it would be if you were up for that.
All righty. Yeah. Are you a subspecialist or a generalist?
I'm a generalist.
Okay. Do you have a specific case that's worrying you?
Not one in particular.
You want something from your list or just a topic? What are you looking for?
Either is fine. Whatever's best for you. I think
Well,
my
I
list
can give.
is
Yeah, go ahead.
September. I was
Say
just going
again.
to say, are looking for my list. I think it's in September.
Because I have a topic, and I like to pick people's brains to see what they would do.
Okay, sure.
Because this happened to me. I'm coming on, and I heard the story about this patient, and
Okay.
I don't know what the right answer is.
Oh,
Um, so let's pick your brain and see what you think. So it's a patient who is a 33-year-old woman. She is a gravida 2 pair 1 with a prior vaginal delivery. She presents with no prenatal care, a positive meth on her drug screen. She's in a transverse lie. She has an elevated blood pressure that was needed to be treated. She gives a history of chronic hypertension. What else would you like to know about the patient?
so I would start by, even trying to obtain more history from the patient if possible, specific to the conditions that you've already listed. Is she on any antihypertensive therapy? Additionally,
She gave a history. She gave a history of having chronic hypertension, had not taken medications in years.
okay. And then regarding substance use, are there any other illicit drugs on board? And if not, what was her last use, like time interval wise, for when the methamphetamine was taken?
She used it that day and
Okay.
was open about it. And she presented just because she was leaking.
Okay. And then other questions I would have, I know we said she didn't have any formalized prenatal care, but any positive pregnancy tests at an outside facility, any one-time ultrasound in an emergency department, anything to give some sort of clue to what gestational age we are.
Unfortunately, she denies that she had gone anywhere for any medical care.
Okay. So at this point, with that history, I would move forward with doing a focused physical exam as well as obtaining an ultrasound. In addition to the lie, I'm interested to know what gestational age we are.
So the ultrasound showed an estimated fetal weight total at 34 weeks and some days. Femur length was at 32 weeks.
Okay.
Baby, as
And,
like I said, was in a transverse lie.
okay.
And she had an AFI of 4.
Okay. And our vitals are, I know you said that we gave treatment, so the vitals are, our blood pressure is improved.
So she walked in with a 170 over 105, and she got 20 labetalol, and she did not require any other treatment after that. Her blood pressure went down. It was not in the severe range thereafter.
Okay. So at,
And also she denied any symptomatology of preeclampsia.
okay. At this point, I would move forward with obtaining new obstetrical labs as well as a HELP panel, including a comprehensive metabolic panel and a CBC. I also would get a cath urine because I'm suspicious that maybe she's ruptured given the AFI and the history of leakage of fluid. So, and I do not want that to falsely elevate my urine protein creatinine ratio. And, out of a abundance of caution at this point, given, there definitely is some suspicion here for preeclampsia with severe features, I would go ahead and start magnesium sulfate on this patient.
So her lab work is completely normal. So platelet count is normal range, 220. LFTs, BUN, and creatinine, all normal. She had a PCR, a protein creatinine ratio of 0.15.
Okay. And when I
So with
also,
that information, is she preeclamptic?
I do think that it is a cloudy clinical picture because the methamphetamine use certainly could elevate the blood pressure. By definition, severe range blood pressure requiring treatment. Um, I would, again, definitely be someone that I would admit and watch for additional blood pressures. But I don't know that she necessarily is preeclamptic. Definitely not
What
based off of
makes you say that again? I'm sorry.
definitely not based off of the labs. There are other criteria you can meet for preeclampsia, but off of her lab work, no.
What would you be looking for in her lab work?
So on the lab work for the CBC, I'm looking for thrombocytopenia with a platelet count less than 100,000. And then on the comprehensive metabolic panel, I'm looking for doubling of the liver enzymes, twice the upper limit of normal. And then a creatinine that is 1.1, or if I have any other prior creatinine in her record, a doubling from a prior number.
And what would be you looking for in the PCR?
0.3 milligrams per deciliter.
And how would you diagnose if she was ruptured or not? You didn't go into that.
So I would start by doing a sterile speculum exam to see whether or not I saw pooling on a speculum exam. I then could also ask the patient to Valsalva or cough to see if with provocative testing I could see a gush of fluid into the vagina. I could get the pH on a nitrazine paper. And we do have the possibility at my facility for doing an amnisure as well. So if I had, equivocal testing, then I would proceed with sending an amnisure.
And what would be like the gold standard to assess if somebody's ruptured or not?
The gold standard, I actually believe, is to instill methylene blue into the.
Something not invasive. I see where you're going, but not invasive like that. Something you could have done on your pelvic exam or your speculum exam.
A fern.
Fern. So the patient's fern was positive.
Okay. So if we are 34 weeks and ruptured, confirmed, and in a transverse lie, then I would discuss with the patient proceeding with a cesarean delivery for delivery of the infant.
So you would do a C-section that particular day?
I believe yes.
So anything you could do in order to improve the chances of the baby doing well in the NICU?
I would give her corticosteroids for fetal lung maturity.
And how does that work? What's the dosing, frequency?
In my practice, I use betamethasone, 12 milligrams, ideally 2 doses, 24 hours apart, and it induces type 1 and type 2 pneumocytes in the fetal lung to produce surfactant.
So would you deliver her that day, or would you do give her the betamethasone and wait till the dosing or the course is completed?
I think it depends. I would discuss with the patient the options at hand of either getting 1 dose of betamethasone and then proceeding with cesarean versus option for admission and to get a completed course of betamethasone, which, I do feel like is reasonable in this setting.
So what makes you push for one direction or the other, of delivery that day or waiting?
I would say that waiting would certainly have fetal benefit if we were able to get a completed course of corticosteroids on board. Certainly, she is at risk for things like intraamniotic infection, possible placental abruption, deterioration of fetal status. So
Would you start any latency antibiotics?
over 34 weeks, I would not start her on latency antibiotics. I would start her on ampicillin for GBS coverage, probably until delivery.
And what is the purpose of the latency antibiotics?
My understanding of the latency antibiotics is that it prevents ascending colonization of the membrane and the amnion that is now essentially exposed to the vaginal flora.
Can you tell me what latency antibiotics you use in your practice, dosing, and why you use those particular antibiotics?
So in my practice, I would, in the appropriate candidate, I would give ampicillin 2 grams, Q6 hours IV for 48 hours. And I would give a one-time dose of azithromycin 1 gram. And then following the conclusion of that initial 48 hours of treatment, I would transition the patient to amoxicillin by mouth. I use 500 milligrams Q8 hours, and I would give that for 5 days.
And why do you use the ampicillin, amoxicillin?
For GBS coverage.
And what about the azithromycin?
I believe it's for enteric coverage, but I would need to double check.
So in your practice, you initially said you would deliver her.
I did.
Okay. And you stick by that? And I brought up other things.
I think, again, assuming that the patient is stable and there isn't any other obstetric indication for delivery, I would at least want to get 1 dose of corticosteroids on board prior to proceeding with delivery, but I do think that she needs to be delivered in the next 12 to 48 hours.
What if I told her her blood pressures remained stone cold normal after that 1 dose of labetalol?
I would use the indication of the PPROM for delivery.
And what's the recommendation in regards to PPROM? When should the patient be delivered?
So you can deliver at any point over 34, but by 37, after a discussion between the patient and the provider on the risk and benefits of the timing interval.
Oh, and here's to be the devil's advocate. What if her dating was completely wrong?
Yeah, I mean, that certainly, I mean, it definitely is a suboptimally dated pregnancy. So we have, plus or minus 3 weeks on either side. But I would say, given the information that I have, that I would move forward with delivering her again in the 12 to 48 hour range.
All righty, let's stop there. What'd you
Okay.
think?
Well, what did you do?
This was a little bit different because I gave you more information. They don't give you that much information, even though I heard some of the structured cases they did last year. They gave a little bit more information each time instead of making it as vague as they used to do it. So, the MFM, the MFM said to deliver her because of her hypertension and because she uses meth. I'm like, well, that's not a good enough reason in my book. That was the reasoning. I mean, I don't know. I don't know. I mean, and I know the person who had admitted her, because initially when I heard the story, I'm like, why didn't they deliver her? But then when you peeled off the onion, you're like, okay, so she has bad dates. She's had no prenatal care. Her blood pressure is perfectly normal now. Could it have been from the drug use? Possible. Her PCR was completely not even elevated.
Right.
So can you call her preeclamptic? Oh, let's call her gestational hypertensive then, because everybody drops that. So, well, gestational hypertensives aren't delivered at 34 weeks, to my understanding. You wait till
Right.
37, correct? But unless
Right.
something changed.
What about the PPROM?
I think I wouldn't go, along. I would at least given her the steroids in my book.
Okay.
That's what I would have done at a minimum. At a
Awesome.
minimum. When to deliver her, but I think it's come to the point, I'm not going to badmouth MFMs because I know we have some on the call, but a lot of MFMs is like, just deliver everybody. That's like there's like no rhyme or reason to anything. Just deliver. It's their answer to everything. And I'm like, well, there should be some reasoning behind it. Now, if her blood pressure was still elevated and there was some issue there, that's different, you know. But in the end, if a patient's unstable because her blood pressure can't be controlled, is she a stable candidate to be delivered anyway? No, she's not.
Right.
You know. So I got a couple of questions here. I don't know what the answer is, but I'm interested in other people's viewpoints. So you initially said that you would deliver her, and I can't say that's wrong. And I don't know how much of a shared decision-making discussion you're going to have with the patient who's high on meth. You know what I'm saying?
Yes. Fair.
Who probably is not going to have, you know, custody of her child anyway. So not that much skin in the game, I guess. So I have a couple of questions here. How do you know if the hypertension is due to meth or preeclampsia? Exactly, Andrea. We don't know. And then I have another question for Charlotte. Can you repeat what you said about the femur length? Was that consistent with 32 weeks rather than 34? That is correct, Charlotte. It was a 30, to my understanding, on the sign out, it was a 32-week femur length. So Andrea, but you could wait if she's not in labor. No, in my opinion, yes. I would have at least given her her steroids because you started it. And then hopefully wait until 34 weeks or if she's in labor. The issue here, Andrea, is that the first ultrasound and the only ultrasound that she had in the pregnancy was that day, and it put her at 34 and like 3. She had already passed 34 weeks. So I don't know what the right answer is, but I don't think she had preeclampsia, just on the PCR. And luckily she didn't have any other symptoms. You know, because I've seen cases where the MFM, they've been sitting on this patient for a month. I mean, she has like platelets are teetering around 105. They keep her pregnant, and she says the magic word, I got a bad headache. Oh, we got to deliver her. I'm like, okay. So any questions on that, Ashley? Good job. I don't know what the right answer is, to be honest with you.
Oh, thank you. I appreciate it.
I don't know what the right answer, but I thought your reasoning was good. And of course, I have to be the devil's advocate. All righty. Anybody else want to be part of the hot seat? Ansi, I'm going in your direction. So I have a question here from Alexandria. She says, I have a lot of these patients on my list, and MFM says always deliver. Ha ha, I agree with you. Well, there you go. I can tell you the NICU people are not happy if they don't get their full steroids. That's for sure. So I had Ansi on. There you are. You're there?
Yep, I'm here.
Awesome. Remind me, generalist or subspecialist?
Specialist, GYN oncology.
All righty, man. So you're looking for OB for
Yes.
office?
I got.
What are you looking for? You have a case?
They just submitted, or they just provided the list for me, but I don't think you guys.
Oh, okay. You haven't submitted it to us?
Right. Unfortunately, I just received it early, like over the weekend or something like that.
Well, they gave you plenty of time. When's your exam?
3 weeks. They only give you 3 weeks.
Nice, good for. So you want to just present the case for everybody on the call, and then I'll see if I can
Yeah,
come up
that's
with
what
some
I was kind
questions.
of thinking.
How's that?
I'll
So
just
this
pick
is an
one.
OB? Is it because you submitted a GYN list? You submitted office, I'm assuming.
Yep.
So OB, so it's an OB. How many cases did they give you?
20.
20?
Yeah.
For all you know, it's you know, because once you submit the list to these guys, they own it.
Oh yeah.
You sign all the paperwork saying, so this could be somebody's list from 5 years ago.
No, I think it's each patient's from a different place because they're all different hospitals. So.
Oh, okay. All right. All right. Well, I didn't know because I didn't know they do that. Okay. So in what category is this particular case?
There's no categories here, but
Oh,
let
really?
me, actually, let me see. I'm gonna look at it differently. Yeah, there are categories. So there's preconception evaluation, patient at risk for preterm delivery, induction or augmentation of labor, labor abnormalities, fetal heart rate abnormalities, operative vaginal delivery, obstetric hemorrhage, lacerations, peripartum hysterectomy, complications of cesarean delivery, second trimester spontaneous abortion, hypertensive disorder of pregnancy, infectious disease antepartum, placental abnormalities, multi-fetal pregnancy, and diabetes and gestational diabetes.
Okay. Do you want to
Yeah.
present a case, or you want me to pick a topic from the stuff you just brought up?
Let me look at one that I
Okay.
don't feel comfortable with.
Okay.
Let's see.
I'm assuming you're good with peripartum hysterectomy. You're good with laceration. You should be good with that.
Hemorrhage, yeah. How
Post-op complication. You should be good with that.
about this one? This one looks like a mess.
Okay.
So this is a 26-year-old G4P3 at 39 and 5. Under antepartum, it says head circumference is 3rd percentile, biparietal diameter 1st percentile. And this is an induction augmentation of labor. There was a maternal and fetal medicine consultation evaluation for cytomegalovirus, Zika, toxoplasmosis, repeat growth scan, induction of labor, and spontaneous vaginal delivery. Well, I guess.
How much does the baby weigh?
37.25, and APGARs were 8 and 9. So I guess not that bad, to be honest. I guess just a low sort of the small for just, or that would be IUGR.
So let me ask you this. Here we go. Let me ask you, what is IUGR? What is the definition?
I believe the definition is less than the 5th percentile. And it can be
5th percentile of what?
On the growth scan, on the estimated fetal weight.
So 5% on the estimated fetal weight. Anything else?
Anything else? I know that it's divided into symmetric and asymmetric
Okay.
IUGR.
So what causes asymmetric IUGR?
Asymmetric IUGR would be where you have head sparing, so that the head, or the abdomen is smaller compared to the head.
So does that happen earlier in the pregnancy or later in the pregnancy?
I would say that generally happens later, and it's a worse prognosis sign.
And if you have an asymmetrical IUGR, what is the cause? Why is it asymmetrical? What causes that type of IUGR?
So it's
does that make sense?
Yeah, so it's head sparing. So I would imagine that it could be related to infection. There's probably both fetal and maternal causes, as well as causes from medications. I don't know off the top of my head what causes asymmetric IUGR, but I would imagine intrauterine infection.
So what type of infections could lead to IUGR?
Torch, for example, I would torch syndrome infections.
So what are those type of infections? Can you name some of them?
Toxoplasmosis, cytomegalovirus, varicella, rubella. I'm trying to think. Parvovirus B19. Zika virus.
Anything else?
I can't think of any right now.
So what causes toxoplasmosis?
I believe it's a parasite, Toxoplasma gondii, and it is there's different forms, the parasite and the cyst, the eggs, and usually infected cat litter, and it's fecal to oral transmission, I believe.
And what is the classic triad of congenital toxoplasmosis?
In terms of findings on ultrasound,
Yeah,
um,
or in the baby.
in the baby, hepatosplenomegaly, ascites, I think they have ventriculomegaly, calcifications in the ventricles. Trying to think. So plasmosis. IUGR, as I discussed, those are the main things that I can think of.
Okay, going back to the IUGR. So you said the asymmetrical had the worst outcome, correct?
Yes.
Okay. Now let's say you have a patient who has IUGR. How would you follow that patient during their antenatal
Antipart.
process? Yeah.
I would recommend antenatal testing with growth scans, and then
How
also
often would you get the growth scans?
I would get the growth scan every 3 weeks, but also the patient would need to have antenatal testing with non-stress test and BPP
And how often would you recommend that?
weekly.
Just once a week?
Um, makes me think that it's maybe now twice a week, but I'm not 100% on this. I would have to look it up.
What else would you do antenatally?
You could look at Dopplers of the fetal head, yeah, yes, and then evaluate just to make sure that
But why the fetal head?
the middle cerebral artery Dopplers, I believe, to evaluate for blood flow.
Is there any another test that you could do to evaluate the blood flow? Not necessarily the MCA?
Umbilical artery, I think, or something like that. I'm gonna have.
Which one may be more beneficial in IUGR?
I'm not sure. I'm gonna have to look this up.
So let me ask you this. When are umbilical artery Dopplers abnormal?
Right. Umbilical artery Dopplers, I believe, is more with uteroplacental insufficiency. But again, this is way out of my comfort zone.
And in regards to, of course, if the Dopplers are abnormal, what's the recommendation? If they were really bad, let's put it that way, if they were really bad, what's the recommendation?
For delivery, if you have,
okay,
I believe if you have reverse and diastolic flow,
if you have reverse, okay, and what else could you have?
you could have absent or present. I believe those are the three findings. And once you start having absent or reverse, that's when you're really starting to plan delivery.
And regardless of gestational age, which type of Dopplers or what findings in Dopplers would the recommendation is delivery, regardless?
Regardless would be the reverse.
Okay. And what about the absent?
The absent, I think it depends on the gestational age.
Okay. Now, let's say you don't have reversal and you don't have absent.
Mm-hmm.
What else is indicative of an abnormal Doppler?
I'm not sure.
Okay, let's stop there. What'd you think? I know it's out of your comfort zone.
A little bit, yeah. I mean,
okay, we're gonna go over it.
Okay.
Quick questions. Go ahead.
No, I mean that's fine.
Okay. Okay, so IUGR. When did you finish residency?
It's been quite a few years now. 10 plus.
10 plus. Well, bless your heart, sitting for the boards. All right, man. Good luck to you. Okay.
Actually, no, a
Okay.
little bit, sorry, 10 plus, no. It's been
Okay.
8, yeah, 8.
Okay. Cool. Alrighty. IUGR. It's not as hard as you think. Okay. So
Okay.
IUGR has changed a little bit, and I'm sure a lot of the people, the generalists, they know this. It's a estimated fetal weight of less than 10th percentile, or an abdominal circumference less than 10th percentile.
I
That's
see.
the
10.
new thing.
Okay.
10th percentile. Now, severe IUGR is less than 5th percentile.
Okay.
So you have your symmetrical and your asymmetrical. The symmetrical occurs earlier, and it's the one that has the worser prognosis. It's due either like torch infections or like a chromosome, like an anomaly, a chromosomal anomaly.
That you're saying that's the symmetric?
Symmetric. Asymmetrical is due to uteroplacental insufficiency, and that's when
Oh,
you have the head sparing and you have the smaller abdominal circumference. That's why the abdominal circumference less than 10th percentile is now a new part of the definition.
I see.
Does that make sense?
Yes. And what is the definition of head sparing? Or I guess asymmetrical?
Asymmetrical, you're sparing, you're shunting the blood to the important parts of the body, which would be the heart and the brain.
Right, but what's the percentage difference, I guess, between the two where you start calling it asymmetric? Like in this case, it's
Oh,
3rd percentile head and 1st percentile biparietal diameter.
yeah, but they didn't tell you about the abdominal circumference.
True. But I guess,
So it could be asymmetrical, but usually with asymmetrical, with uteroplacental, they in essence they measured it wrong. That's
I
what
see.
happened with the baby was 37.25 grams. They measured it wrong. Probably the
Right.
baby was lower in the pelvis. The tech that did it had bad, BPD measurement, and
Right.
therefore that affects the head circumference. Yeah. So that's why the abdominal circumference less than 10 percentile is for the asymmetrical. That's a new definition in the last, I think, year or two in regards to IUGR. Does that make sense?
Yeah,
So symmetrical, the entire baby is small.
gotcha.
So that's why the estimated fetal weight comes into play, the
Got
complete
it.
weight. Does that make sense? I'm not an MFM.
Yeah.
So you want to do antenatal testing twice a week. And to my understanding, this is the way I understand it. For 7 days, if you do antenatal testing and it's reassuring, this baby should do well for the next 7 days
Mhm.
unless something unexpected occurs, an abruption, a cord accident, right?
Mhm.
So 7 days. So if the patient has an issue, then they add that twice a week. So that way, that standard deviation, you can miss somebody, which is very low, you catch it sooner, right? So the recommendation would be an NST twice a week, and one of the days you could do what's called a modified biophysical, which is just an AFI and an NST,
Mhm.
or you do the biophysical completely.
Okay.
Because the one thing the NST does not tell you, it does not tell you the fluid. And if you have uteroplacental insufficiency,
Doesn't tell you what, I'm sorry?
doesn't tell you the fluid, doesn't tell you your AFI, correct?
Right. Yeah, yeah.
Right? So
Mhm.
if if you have uteroplacental insufficiency,
Right.
what could happen?
Oligo,
Exactly. Do you understand why you would have oligo?
less perfusion of the placenta, and you're not producing, well, the baby's not peeing, basically.
Exactly. Exactly. Does that make sense?
All right, so again, symmetric is the torch, asymmetric is uteroplacental insufficiency.
Yes.
Okay.
Now, when are umbilical artery Dopplers abnormal? To my understanding, it's the umbilical artery Dopplers that they focus more on in regards to IUGR. I know some MFMs do MCA. I don't know how that comes to play, but I know definitely do MCA if you have alloimmunization. That's a completely different entity.
Got it.
Okay.
That's
I'm
very
not
well.
an expert. I can ask after we're done discussing to any MFMs that are on the call. So if your SD ratio is greater than 95th percentile for the estimated gestational age, there's something going on. And really, to my understanding, Dopplers are only beneficial if there's a concern for growth.
Okay.
Restriction, you're checking to make sure everything's looking good. If you have complete reversal of flow, she has to be delivered. Doesn't matter the gestational age, because that baby will die. It's just a matter of time, and the time's not on your side. Absent, I've seen them sit on that, and literally the patient is getting, like, she's on the monitor the entire time. Because I work in a very high risk center, the patient's on the monitor the entire time. If they can make sure they're not missing anything. And she gets Dopplers on a daily basis with biophysicals.
One other question.
Yes.
I was just thinking, looking at this, Zika can cause microcephaly. I mean, is it possible, I don't say it, but is it possible to have a normal weight, but then have microcephaly?
I would think, oh, yes. I'm not an expert, but I would say yes.
Okay.
Unless it's like the head is so small. But I've seen a lot of times they'll say it's a small head, and everybody gets freaked out and the baby comes out fine. But again, I'm not an MFM. Okay. In regards to torch, toxo, syphilis, rubella, CMV, HSV, parvovirus, literally any infection. Toxo is a protozoan parasite, like you said, the Gandhi, classic triad, chorioretinitis, hydrocephaly, intracranial calcifications. Some torch infections can cause polyhydramnios. I know I've seen case lists where people do like the full torch extensive workup because of the poly, and the chances, according to UpToDate, that torch polyhydramnios is due to torch is 0.6%, so really low. So you spend lots of money on testing that may not be of any value. And what's the most common cause of polyhydramnios? It's idiopathic. We can't figure out why. Okay. I have a question here. Is there a standard answer for how many weeks gestation will start antenatal testing and Dopplers? It all depends when you discover the IUGR. So if I'm not mistaken, Ryan, you're an oncologist as well. So if you're a diabetic, if you're a hypertensive, I'm talking about type 2 diabetic, A2 diabetic, chronic hypertensive on medication, if you're concerned about preeclampsia early in the pregnancy, that's a little bit different. But usually by 32 weeks, if you're a chronic hypertensive on medication, you're a diabetic A2 on insulin, or on a hypoglycemic if you're not giving insulin, or you're type 1 or type 2 diabetic, you start at 32 weeks unless there's some concern about control. Now with the IUGR is when the IUGR is diagnosed. Okay, that makes sense. Okay, do we have an MFM on the call? Anzi, I'm gonna keep you on the call here, see if they wanna add anything else. Can you put in the box if you're an MFM and are on the call? Nobody's responding. Okay, Janelle, let me go to your direction. Okay, hold on. And I can't find you, Janelle. I know I saw your name, but now I can't find you.
Thank you for that. Appreciate it.
Hold on. I'm gonna get Janelle here on the call. She's an MFM. See,
Okay.
Janelle, you're there? Would you add anything else?
The only thing that I would edit is for reversed flow. It's between 30 to 32 weeks. So I mean, I have managed expectantly like fetuses that were diagnosed in the second trimester with growth restriction, but I mean that's probably not on most people's case list, but that's just the one edit. Everything else was right.
So 30 to 32 weeks, you would sit on reverse? Wow.
Yeah.
Really?
They'll be admitted.
Oh, to be admitted. Well, you know,
Yeah,
because I work in a high risk center, and anybody gets reversed, it doesn't matter the gestation, they're delivered, period. And but
yeah,
like I said, we keep the babies on the monitor the entire time,
yeah. No, we don't. I mean, ACOG, it's reverse 30 to 32, and then absent is 33 to 34. No, even
Okay.
even reverse, we don't keep them on the monitor the whole time.
Like I said, in this particular facility that I work at, you know, we've had pretty good outcomes in some really like messed up cases,
yeah,
because you could see exactly when it's going downhill.
yeah.
I'm not
But
an expert, so I said I'm not an MFM. So they're saying 30 to 32 weeks if
yeah,
you could sit on reversal. And
yeah,
then I guess once you hit 34 weeks, I should, yeah, that's correct. I should preface that. If you have apps, if you can make it to 34 weeks and you have any concerns with that um, absent of flow, then you should deliver for sure. So my apology, you are correct.
yeah, no problem.
Anything else? Anything else you'd like to add on torch? I'm not very good at torch stuff. Any quick like overview on torch?
Yeah, I mean,
Anything else?
I guess to add to that, so early onset growth restrictions defined as less than 32 weeks. For those babies, you get more concerned that there is like an underlying genetic or infection cause. We'll offer all of those patients amniocentesis with a chromosomal microarray, and then SMFM says just to only routinely do CMV on the amniocentesis. And then if it's ultrasound findings concerning for something else, like, you know, if you see the calcifications or the other stuff listed, then you can test for other things. But we routinely only test for CMV. Yeah.
So
Can you
like in this,
yeah, go ahead.
so like in this case where what's listed for me is just the head circumference less than third percentile. And then
Yeah.
they're testing for cytomegalovirus, Zika toxoplasmosis. I mean, I imagine that's what they want me, or maybe they'll ask me about, or.
Yeah, because that does meet the definition for microcephaly. Well, there's no agreed upon definition for it, but anything less than 2 standard deviations, you can call microcephaly. So that would be it. And so that's why they tested for those things.
Okay, thank you.
But let me ask you this, Janelle, seeing that the weight of the baby was fine, they probably measured wrong, or that's a misinterpretation on my part.
I mean, you can still be microcephalic with a normal weight. So yeah.
And this might be a dumb question on my part. What is the consequence of having microcephaly? Does that mean the baby's not going to be smart? Do you understand where I'm coming from? Like, what's the big deal? Maybe it's wrong me bringing that up.
There are associations with
Okay.
development, and then you do have to go looking for infectious causes, and there are a bunch of genetic syndromes associated with it too, which I
Okay.
don't know in my head, I'd have to look up, but that's what you go looking for essentially.
Can you go over for everybody on the call CMV? Because CMV it'd be something that they could ask.
Yeah. So CMV, I mean, we get most concerned about it on ultrasound with early onset growth restriction, like I mentioned. And you can have other findings of it, like ventriculomegaly, hepatosplenomegaly, microcephaly is another one. And then most of the cases that I've only seen a couple cases, but I've had a couple moms who were diagnosed with CMV in pregnancy, like mono-like illness, and are diagnosed. And really with those patients, you can offer them an amniocentesis to try to diagnose fetal CMV. You have to do that 12 weeks after the infection, or you can just follow up ultrasound findings, but there's no treatment, really nothing to do.
Remind me, because I always get confused. The earlier you get the CMV, is it the less chance you will have sequelae at birth, or is it vice versa if you get it later in the pregnancy? Because I always flip it in my mind. Do you know do you understand the question I'm asking?
I know. I'm looking at my notes now on this because I don't remember. I'm not sure. Okay, here I have it. Risk of transmission increases by trimester, but sequela is worst in the first trimester.
So it's worse in the first trimester than the third. So the earlier you get it, the worse the outcome, possibly.
Yeah.
And to my understanding, there's a chart or an algorithm on UpToDate in regards to this, the CMV and pregnancy, that you have to wait the 12 weeks so you can build the immunity so it can cross the placenta. Am I correct? And then that's how you test for it. Because if you test too quickly, it comes back negative.
That's correct. Yeah.
I have one last question. What else could cause microcephaly? I was thinking, is like alcohol something, like fetal alcohol syndrome?
I have to defer to Janelle. I have no idea. It makes sense that it would.
Just thinking of the differential for that, besides just the infection for the microcephaly.
Are you there, Janelle?
I'm here. I'm trying to look. That sounds right. I don't know if that. I don't know it off the top of my head if it does.
It does make sense if you want to look that up and see. I would. So I've learned something new today. Again, I'm not an MFM.
I appreciate you discussing this. Thank you.
No worries. Well, good luck, okay?
Appreciate it.
Alrighty. And I have here a comment from Emily. She's also an MFM fellow too. She agrees with Janelle about the reverse and inpatient admission, but not continuous monitoring. I didn't intend to say that that's the standard of care. So my apologies if anybody thinks that's the standard of care, because I know the place that I work at, that's not, this is what they do. It doesn't mean it's standard of care anywhere else. So my apologies if anybody, is thinking that. Okay. All righty. So seeing that I picked on Janelle, I'm going to see if she wants to be part of the hot seat.
Sure.
You want to be part? Now, have you been on recently? Because I'm trying to be fair to everybody.
I was on yesterday, so if someone else wants to go, that's fine.
Okay, cool. We'll get you next week. How's that?
Sounds good.
All right, cool. Anybody that was not on the hot seat in the last couple of days, we're just trying to include everybody. I'm going your direction, Andrea. Says you're self-muted. There you are. How you do? You haven't been on the last couple of days?
I was actually on yesterday, but
Okay. Let me ask who wants to be. I'm gonna make it easy. On the question box, who did not go yesterday or the day before and wants to be part of the hot seat? And I will go to you because I have a couple people hands up. Here we go.
okay.
All right. Ryan, thank you, Andrea, for being honest, and thank you, Janelle. We'll catch you next week. Ryan, I'm going in your direction. You there,
Great,
Ryan?
thank you. Yep, can you hear me?
Yep. You're Onc, right?
Yep, Onc fellow. Mm-hmm.
All right. Perfect. So you're looking for OB. What are you looking for?
Honestly, dealer's choice. If you find something on the OB list you want to ask about, but
You want to do office? We haven't done office today.
Yeah, we can do office.
You want a topic or something on your list?
Let's do a topic.
You want to do a topic? All
sure.
Right. And I'm going to be really mean because I know you're an oncologist.
Please do, yeah. I deserve it.
So can you discuss for me your infertility workup?
Yeah, definitely. So history and physical is definitely important for the patient who walks through the door. So with the history, sexual history, previous history, partner history is also important. Does the partner have any previous children? Age obviously is an important factor. Physical exam, does she have any risk factors that could preclude infertility, such as endometriosis or other things like that? Previous cancer history. So also in the workup, I'd want to start with just basic lab work. So you can look at FSH, LH, estradiol, progesterone, DHEA-S, go from there.
And what would the DHEAS help you with?
It would show us if there's an adrenal source of exogenous hormones or androgens from the adrenal glands, which could also, cause infertility, but also a slew of other issues.
So let me ask you this: what would you anticipate all that lab work to help you with if the patient told you she had normal menstrual periods?
Oh yeah. If she was having normal ovulation, and that's another thing I forgot to mention, just like her ovulation and menstrual history as well. But yeah, if she was having normal menstrual periods, it may not be of much help. I brought it up more so to see if it was, I was thinking more along the lines of more of like a hypothalamic pituitary ovarian axis issue versus ovarian issue. If these are the cases, but yeah, if she's having normal periods, it may not be of much help.
And let me ask you this: what differential can you give me for a patient that may be having some difficulty conceiving?
Yeah, so she could have just idiopathic infertility, just a natural cause, endometriosis, other partner factor infertility as well, PCOS, things like that. I think that's less likely if she's having regular ovulatory cycles.
Yeah, I'm changing the story. I said she didn't have normal ovulatory cycles.
Oh yeah. Okay,
yeah,
great.
So,
sorry. PCOS.
Mhm.
Other like so PCOS would be more along the lines of like hypothalamic pituitary. Other things you could think of like primary ovarian insufficiency or like early menopause, or even some of the more rare things like gonadal dysgenesis with Turner. Also, could be mechanical, so whether it's like a uterine septate uterus, or like Asherman's as well.
So you do your lab work. Any other testing in your infertility workup that you would do?
You could do a semen analysis on the partner as well. I know.
Let's say that returns completely normal. Any other testing?
You could do an AMH. That could tell you, the viability if she were to undergo reproductive infertility.
And what would the AMH tell you?
I did know this at some point. I think it's more so ovarian reserve, and I think it's I know we're not supposed to say in studies or data, but I think it tells us mostly how successful reproductive technology will be for this patient in getting a functional egg, but I may be completely wrong.
Any other testing in your workup?
You could do a sonohistogram or a sonohistogram, and you could look to see if there's like a uterine or tubal factor.
So the sonohistogram will help you see a tubal factor? How would it do that?
No, it would probably just show the uterine cavity. Then you could do a hysterosalpingogram for an HSG and look in laparoscopically to see if there's any tubal patency.
You said hysteroscopically?
Oh, sorry, laparoscopically. Yeah.
Okay.
Mhm.
So let's say you do your workup. Let's say you diagnose her with PCOS. How would you diagnose PCOS?
So PCOS, you have the so it's 2 of 3 categories. I want to say it's the Rotterdam criteria, but it's anovulation or irregular menstrual cycles is 1 for a period of time. 2 is hirsutism or any other signs of androgenism, hyperandrogenism. And 3 is polycystic ovaries. So I believe the number's like 12 or greater antral follicles seen in the ovary on ultrasound.
What size follicles?
Ooh, I'd have to look that up.
Anything else on ultrasound that'll push towards the diagnosis of polycystic ovaries?
I know that the characterization or the follicles being on the outside. I remember something about like a string of pearls appearance. So if they're more peripheral around the ovary, I think that could be a sign of PCOS as well.
So let's say the patient has PCOS, semen analysis is normal, hysterosalpingogram shows patent ovaries and a normal uterine cavity.
Got it.
What would be your management for this patient to assist in her conceiving?
So with PCOS, so it seems like PCOS would be the culprit here. So quite a few things. First, I would start with diabetes testing in the patient. So obtaining an A1C, possibly a fasting glucose as well. If there is obesity involved or any metabolic syndrome, counsel on weight loss and exercise activity. So starting with those things. As far as medication for her, letrozole is effective and approved in patients with PCOS to help assist with fertility.
And what's the mechanism of action of letrozole?
It's a aromatase inhibitor, so it prevents the conversion of, I know it prevents the conversion to estrogen. I forget the precursor. But yeah, prevents the conversion of androgens. I got to read up that steroid chart. I have to look back through that.
So you would start her on letrozole. Can you discuss your ovulation induction protocol with letrozole?
I'd have to look further into the actual dosing and the regimen. I do know I did memorize it for Clomid, which may be effective as well for PCOS, but I know not as effective as letrozole in certain cases.
So tell me the Clomid protocol.
Yeah, so Clomid is it's an estrogen analog. So it basically fills the receptors and tricks your brain into thinking it needs more estrogen. In the protocol, it's 50 milligrams for the first 5 days after cycle, or the first 5 days of the cycle. And you advise the patient to begin intercourse with her.
Let me interject you. So the first 5, so which is the first day of your cycle?
Oh yeah, so cycle day 1 through 5. So it'd be the day 1 of the follicular phase.
Okay, so you get your period, you see bleeding. If you did a withdrawal bleed, that first day you get bleed, that's when you start the medication. Am I correct? Is that what you're saying?
Ooh, yeah, but I believe so. If that's the first day of the cycle, yeah. So I would do Clomid. I'd start with the low dose of the 50 milligrams, days 1 through 5. Wait 5 days, and I'd say cycle day 10. The patient can begin intercourse with a partner every day or every other day for about 7 days, and I would give that a few tries, and if not, you could always go up on the Clomid. I believe up
and
to
how would you
100 milligrams.
How would you assess if it was beneficial?
Well, obviously the ultimate, or I guess the ultimate goal, the touchdown would be to,
To get
achieving
pregnant.
pregnancy.
But,
Yeah.
but before you can figure that out, how can you assess if she ovulated or not?
Oh yeah. I would use ovulation kits. Those seem to be pretty effective. And you could get those
Anything
over the
else you could do?
counter.
Anything else you could do?
I guess you could check a mid-luteal phase, progesterone.
And when would that be drawn?
So if it's mid-luteal phase, I believe probably anywhere cycle day like 17 to 20 maybe. So
and,
after, I guess it would be after ovulation, yeah.
And anything else you could do to assess if she ovulated or not?
I'm sure there's some, not that I know of, but I'm sure there's something else.
Let's say she does not ovulate. What would you do?
Yeah, so if she doesn't ovulate from either, if she's unsuccessful with letrozole and clomiphene, and you've gone up, and you could always go up on the doses, I guess. So you could go up.
So with your, because you said you memorized the Clomid regimen. So what would you do with the Clomid?
I'd go up to 100 milligrams, or I believe you could go up to 150 as well. So you could keep going up in regimens of 50.
So let's say the patient is successful in ovulating at 100 milligrams. What would you do?
If she's successful in ovulation,
test is positive. So what would you do?
Yeah, to her and her partner to begin. So I tell them, on days, cycle day 10, begin having intercourse with their partner every day or every other day for about a week to a week and a half. But yeah, I tell them to get to work.
So then, how many cycles, if they're ovulatory cycles, would you give her the Clomid for?
Cycles, how long? I believe 3 to 6, but I'm not sure.
Okay, let's stop there. Sorry.
Oh no, that was great. Thank you.
Well, it was because you're an oncologist. Letrozole is not, to my understanding, yet FDA approved for ovulation induction, so you have to let the patient know that.
Oh, got it. Okay, I was
okay,
mistaken.
because you said it's approved. It's not FDA approved yet, to my knowledge. Okay. Letrozole and Clomid is the same protocol for both. It does not change. Okay, you're correct.
Okay.
The Clomid is 50 milligrams, 100 milligrams, 150 milligrams, and you increase the dose if you're not successful in ovulating. Once you're successful in ovulation, you stay at that particular dose. Letrozole is 2.5 milligrams, 5 milligrams, 7.5 milligrams. Got it. And the reason letrozole is favored in PCOS and BMIs greater than 35, greater than 30, is because the studies, don't say studies, show that letrozole has a 20% live birth rate compared to 10% of Clomid in those particular type of patients. And what's the goal? It's to get somebody pregnant. Letrozole it blocks conversion of androgen to estrogen. Clomid inhibits normal estrogenic negative feedback, which results in an increase in pulsatile GnRH secretion from the hypothalamus and subsequent FSH-LH release. Okay, there's two different types of protocols, for lack of a better word. You either start on day 3 or day 5 of the cycle. Got it. Because day 1 is the first day you would have the bleeding. I don't know why they say the earlier you start, the more successful. I'm not an REI. This is what, I don't know what the pathophys of that is. I read it once and I don't remember. So either day 3, so you take it from day 3 to day 7 for those 5 days, or day 5 to day 9. Got it. Okay. Perfect. So if I have a regular 28-day cycle, it would be a day 21 progesterone. Or
Got it.
you could do an ultrasound and you want like a follicle greater than 2 centimeters or 20 millimeters.
Okay.
Does that make sense?
Yeah, definitely.
And usually, if I'm not mistaken, you should start having relations at, you know, at the latest would be 5 days after the last pill that you take.
Got it.
Again, I'm not an expert. In regards to PCOS, the string of pearls is not a requirement. It is greater than 12 cysts, 2 to 9 millimeters in size, or greater than 10 cc volume to either ovary.
Got it.
Okay. I thought your workup was fine. I have Alexandria, who is an REI, saying that you could do a sonohistogram. However, and I know that for a fact, that they can assess tubal patency by seeing bubbles. I've never seen it. To me, it's easier just to do a hysterosalpingogram. Number one, it's much more painful. Number one. Number two, and some patients do get pregnant after a hysterosalpingogram. I guess the pressure of putting the dye through, it kind of unclogs the fallopian tubes.
Got
So
it. Yeah, I remember that.
I had a patient, she wanted to get pregnant. She always came in for a hysterosalpingogram. She's like, I always get pregnant after my hysterosalpingogram. I was like, okay, you pay for it cash. So I was like, all right.
You've got the
And
lucky
what I'm
touch.
saying is we do REI here. I'm an REI, and we do this in the clinic. So cha-ching for Alexandria doing a sonohistogram in the office. So questions on that? So good job. I mean, you know, this is out of your wheelhouse.
Thank you.
Any other questions?
Still got some time to study. So thank you.
Yep, no worries. Good job. So Alexandria, I'm going in your direction because I see somebody is offline, so that they had said that they hadn't been picked. So I'm going to Alexandria R. It says you're self-muted.
Hello?
Are you there?
Yeah, can you hear me?
Yes, I can. And you haven't gone in the last couple of days?
No.
Okay. Just trying to spread the wealth, for lack of a better word.
Yeah.
You're a generalist, correct?
Yes.
What are you looking for? Are you looking for to discuss a specific case?
I do have one on office.
Okay. Okay, let's go look for it. I think this has been a good session. I learned stuff today. Hopefully you have too, Alexandria.
Oh yeah.
Office. Okay. Which one? Which number?
Yeah, it's case 20, but then also it kind of ties into this is on the last page. It's about breast, essentially, because I have a diagnosis of breast cancer and I just want more practice with, you know, breast pathology and all that stuff. So case 20. I'll try
But then you said the last case 40?
I think or 39 and 40 both. Well, 39 is just a young girl with like her family history of breast cancer.
Okay.
So I guess I wanted just more practice on, you know, questions
Okay,
surrounding
so
all of that.
one. Okay. Okay, hold on, let me magnify this. All right, present the case 20 for me.
Yes, so this is a 52-year-old G1P1. She came in for her annual exam, nothing abnormal on her physical exam. She had no complaints. She was due for her annual mammogram. She had one the year prior, which was negative. And on this one, there was a cluster of microcalcifications. She was diagnosed as BI-RADS 4, proceeded to have a biopsy, and found to have ductal carcinoma.
Can I interject here? Can you discuss the BI-RADS system for me?
Yeah, so this is the system that's used for breath pathology. And it's a scale, it goes from BI-RADS 0 to BI-RADS 5, I believe. So a score of BI-RADS 0 would mean almost as an inconclusive test. BI-RADS 1 is negative. BI-RADS 2 and 3, those are the ones that get confused or I mix up. I know BI-RADS 4 is highly concerning and the recommendation is to proceed with biopsy. And BI-RADS 5, I believe, is diagnosed cancer.
Continue with your presentation.
So this patient had a core needle biopsy and she was found to have ductal carcinoma in situ. She was then referred to a breast specialist or breast surgeon, and options were discussed with her as far as either doing breast conserving therapy versus a mastectomy, lumpectomy, and the patient chose a partial mastectomy with clear
And
marks.
what if she had decided on, you said conservative management?
Yeah, my understanding is now with ductal carcinoma in situ, patients have the option for breast conserving therapy, which typically is a lumpectomy. And then depending on the results of that, they could be candidates for radiation, or they may be candidates for what's sort of like an endocrine therapy, depending on
What do you mean by endocrine therapy?
I'm trying like a medication, whether it's tamoxifen or I can't think of what name I'm thinking of.
An aromatase inhibitor.
Yeah.
Does that sound familiar?
Yes, I think so. I'm not sure where I'm going, but I know that she may or may
I think
not.
it's an aromatase inhibitor.
Okay. Okay. Yeah.
Continue.
So she chose a
for the
partial
partial mastectomy. Okay.
Yeah, and then I saw her in the office after, and she was still ongoing radiation for her diagnosis.
What if she had declined any treatment? What would you tell her?
When I first saw her after I had the diagnosis of the ductal carcinoma in situ, I brought her in with her family, and we did have a long discussion on my understanding as far as, right, I let her know I wasn't the specialist, but my understanding on what her options were. Letting her know that at the end of the day, it is up to her whether or not she wanted to do anything. But knowing what I know about ductal carcinoma in situ, it is treatable and it does respond well to treatment. But at the end of the day, it would be her choice what she wanted to do.
Now, could you have quoted for her any statistics in regards to if she did not want to do anything, how it would have proceeded, being that it was in situ?
Yes. I don't know what the statistics is. Oh my goodness, the statistics are off the top of my head. But it's something I would definitely look up and research for her.
And when they say she had carcinoma in situ with ductal and lobular features grade 2, what do they mean by the grade 2?
I believe that pertains to the histology of the tumor, but I'd have to look at it, or I'd have to look more into it.
And how much radiation? She's just getting radiation. She's not getting any chemo, correct?
Correct.
And she's going to get the radiation. How is she getting the radiation?
I'm not sure.
Okay. And then after the radiation is completed, then she'll start on like tamoxifen or an aromatase inhibitor.
That's my understanding, yes. When I had asked her that, she wasn't sure, but from just doing my own research, I believe that she would be a candidate for it because she was ER positive, I believe is what her pathology came back as.
Now, do you have any understanding of who's a candidate to be on tamoxifen versus an aromatase inhibitor?
Yes, I'd have to look a little bit more on the aromatase inhibitors. It's escaping me which one they can use. But as far as tamoxifen, it can be used for patients like this who did have a confirmed diagnosis, but tamoxifen can also be used in patients who have a BRCA1, BRCA2 mutation in order to kind of decrease their chances of developing breast cancer.
And this patient is premenopausal or
She's
postmenopausal?
she's postmenopausal.
So does it matter which medication you start?
Yes, I believe on someone who is postmenopausal. Now I'm confusing this with osteoporosis because I'm like, I think you start one before them, but I would say yes, there's another medication. She would probably be a better candidate since she is postmenopausal.
All right, let's stop there. I'm sorry, I'm not very strong on breast issues.
It's okay, neither am I. That's why I
So let me go over BIRADS because I got that little buddy written up here.
okay.
But there's one that oh gosh, this is like in the crevices of my brain. I think if somebody can put in the question box, I think you have to be menopausal to be on an aromatase inhibitor. And
That's
I think
right.
it used to be like that for tamoxifen, but that's since changed, if I'm not mistaken. Go ahead, I'm sorry.
No, I think that's right because then if they're on an aromatase inhibitor and they're premenopausal, you can cause them to ovulate. So you want to make sure they're also on birth control, right?
I can't comment on that. I'm sorry.
Okay. Okay, no, it's okay. I'm just kind of trying to
I just
think
cannot.
through it. Okay.
Yeah. So Lauren is saying anastrozole is postmenopausal. That's correct. That is correct. Only tamoxifen for premenopausal women. Wow, I can't believe I remembered that.
Okay.
That's from Alyssa. Thank you, Alyssa. This is not a strong point in my wheelhouse of knowledge. BIRADS, category 0 is incomplete. Category 1 and 2, benign findings. Category 3, probably benign, less than 2% likelihood of cancer. Recommend follow-up in 6 months. Category 4, suspicious for cancer. A fibroadenoma, it would be RADS 4. Okay? Because they don't know, they have to biopsy it. Category 5, high likelihood of cancer, greater than 95%. And I believe they have another category, but this is what I read. This was in up to date. I think category 6 is you have cancer.
Oh,
like it's no cancer, I believe, but don't quote me on that. What other things they can ask? Well, the year before she was fine. That's just terrible. Poor lady.
I know, it was sad.
But I would find if she, because I know that it's a high rate. I know it's in situ, but the risk of it becoming cancer and spread, and passing, the basement membrane, or lack of a better word, is very high. So that's why the treatment is so highly recommended. But I can't tell you the statistics, but it's very highly recommended. I believe the lower the grade, the less disorganized, but you would have to look that up because I'm not sure. So grade 2, she's in like the going towards, because grade 3 I think would be the most disorganized.
Correct.
Am I making sense?
Yeah.
I could be wrong. I'm like I said, I'm very weak with breast.
Okay.
I didn't put any breast disease on my list at all. If I was going to put anything, it would have been mastitis, because that I understand well, but I'm not very good with breast. And I would just find out like what they would just like what type of radiation, like what her regimen was.
Okay.
I'm trying to think what else they would ask. I can't think of anything else. Again, this is not my strength. I'm trying to see if anybody else has any questions on the. Nobody else has put any other questions. Anybody an expert on breast disease, if they want to add anything, because I know I'm not. Nobody's putting anything down. I wish I could guide you in a better way.
No, that's okay. I think just even getting
Um,
asked these questions is helpful.
You know, try to think what else. I mean, I would look into like discharge from the nipple,
Okay.
just in general, in regards to breast. So
Mhm.
everybody thinks bloody is the one that's really associated high risk of cancer. Believe it or not, clear discharges.
Okay.
Milky will not. If you have green, that's an intraductal papilloma.
Mhm.
I can't believe I remember that, but yes. I mean, hopefully she has a good, and just the overall, if radiation is given, what's her chance of survival, 5-year survival rate, blah, 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 blah.
Okay.
And if she takes the tamoxifen or the aromatase inhibitor, how would that change? And how long she should be on it. That being said, if she's on tamoxifen, what does that do to the uterus?
Right. Yeah.
Right? I could see
Mhm.
them asking you questions on that. Increases the polyps,
Yeah.
you know, hyperplasia, blah, 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 because of the polyps, so on and so forth.
Okay.
Okay? I'm sorry, I
Yes.
wish I could guide you a little bit more.
No, this is great. Thank you.
All right, yeah, no worries. All righty. I'm just gonna check the box here, see if anybody had any other questions or comments or statements. So Christine, okay, I have here. So Anzi is saying that is correct. I remember reading that. Tamoxifen side effects: cataracts, uterine sarcoma. Okay. For DCIS, if you choose a lumpectomy, breast conserving treatment, usually you need radiation. If you choose a mastectomy, you likely won't need radiation. Thank you, Christine. Appreciate the input. Again, this is beyond my wheelhouse. But you saying that kind of is jogging something in my memory that I read a long time ago. All righty. We'll see if we can squeeze one more person. I know we're past time, but maybe we could squeeze one more person in the hot seat here. Let me see who has not gone. Anybody else is interested in going on the hot seat? We've gotten everybody that had raised their hand and said they hadn't gone. Is anybody else interested? We're going to put one more person short hot seat here. I'm seeing who has their hands up here, and then. All right, I'm going in your direction. Alexandria S.
Hi.
You're there.
Hey.
Hey, how we doing? REI, correct?
Yeah.
Have I said anything out of turn?
No, you were great, and Ryan did great
Oh,
too.
no.
He's my friend from medical
So you
school.
did good. Yeah, for. Say
He's
again,
a
I'm
smart.
sorry.
He's my friend from med school. He's a smart guy.
Oh, okay, awesome. It's great how everybody just knows each other.
Yeah.
It's awesome. So what are you looking for?
Why don't we do office, because no one ever really does that with me.
Okay, office. Do you have a particular case or no?
No. Or you can do GYN on whatever. I've done a lot of OB
No,
prep.
I don't care. Whatever.
Um,
No, that's cool. No worries. I'm trying to think of something.
we could do office.
Do office? You want a topic or something in particular from your list?
Just whatever you want.
I'm trying to think, because you're an REI. What can we come up with? The pressure. All right. What is the minimum criteria for diagnosis of PID?
They need generalized abdominal pelvic pain and either fundal tenderness, adnexal tenderness, or cervical motion tenderness.
So just need one of those.
You need
Right?
abdominal pain like chronic abdominal pelvic pain and one of those.
Okay. So you don't need fever, discharge, none of that.
No, those are, I believe, supporting factors that help aid in the diagnosis.
So in what situation should a patient be admitted for the treatment of PID?
A patient that is unable to tolerate PO, patient with a fever, leukocytosis, patient with sepsis, someone that you cannot rule out acute abdomen, consider in pregnancy.
Anybody else or anything else?
Someone that's unstable.
Let's say the patient's HIV positive.
Not necessarily. If I think, if the person, if you don't think that they will follow up or they're not reliable, or you're concerned that they could have a more severe infection, then, but I don't think it's an absolute indication for admission.
And how would you treat the patient if she had to be admitted?
I would treat them with ceftriaxone, doxycycline, and flagyl.
Can you give me some dosing?
Yeah, ceftriaxone would be a gram IV Q24 hours. Doxycycline would be 100 milligrams BID, PO, or IV. And flagyl would be 500 milligrams PO or IV, Q8 hours.
And so let's say the patient gets admitted and she starts the antibiotics, and in 24 hours later, she's not improved. What would you do?
I'm assuming she probably had imaging on admission, but I'd probably re-image to evaluate if she's kind of developed a TOA and consider broadening my antibiotics.
How would you broaden your antibiotics?
You could switch them to Amgen and Clinda. But I think I would really rely on re-imaging, and I would get a white count, like a CBC, to assess her white count.
Why would you switch her to Amgen and Clinda?
I guess it has the same coverage, huh? So maybe to Zosyn.
So you'll stop everything and give her Zosyn?
Yeah. I mean, after 24 hours, I'd probably continue her for another 24 hours to see if she's improved. But I would be worried about an abscess and that the antibiotics are not penetrating the abscess.
So let me ask you this. If somebody had an abscess on imaging, it showed a 5 centimeter abscess, and she was responding to treatment, would you consider drainage, or because she's responding, you would continue the current management?
I would look at the clinical picture, but I think that if someone's responding and it's 5 centimeters, I would stay the course with the IV antibiotics.
Is there a certain size to the TOA that would, even though she was improving, you would say, I think it needs to be drained?
I think 7 to 8 centimeters, she could benefit from drainage via like IR percutaneous drainage.
And let's say she's not improving and she has a 4 centimeter abscess. What would you do?
I would consult IR at that time for drainage.
Regardless of the size?
Yes, if she was not responding.
Now, let's say the patient had an IUD in situ. How would you manage that situation with this PID?
If she just had PID, I would leave the IUD in situ and continue the treatment.
Any situation where you would remove the IUD?
If she had actinomyces, I would remove it. Or if she had a TOA, I would remove it.
Any other situation?
Not that I can think of right now.
What's actinomyces?
It's some kind of bacteria.
What type of bacteria?
I'd have to look that one up. I think you treat it with sulfa drugs.
Going back to the patient that's admitted to the hospital parenterally,
Yep.
let's say she improves. What would you send her home on?
I would transition her to PO, doxy, and flagyl to complete a total of a 14-day course.
Any other testing or recommendations you would have for the patient because of this diagnosis of PID?
Yeah, if she was diagnosed with, had positive cultures for gonorrhea and chlamydia and given her PID, she's at high risk for other sexually transmitted infections. So I'd also test her for trichomonas, hepatitis B, C, and HIV. And I would discuss that she's at risk of having various like sequelae from her PID despite treatment. She still is at a risk of infertility and potentially adhesions and abdominal pain, chronic pelvic pain. And I'd have her, if it was gonorrhea or chlamydia, get a test of reinfection in 12 weeks when I see her in the clinic.
You broke up. You would do what?
A test of reinfection in 12 weeks when I see her in the clinic.
12 weeks. Gotcha,
Yeah.
gotcha. No test of cure. Who do
No,
you do a test of cure on?
I don't believe you do a test of cure on anyone anymore. I think it's just a test of reinfection in 12 weeks.
Sure about that? I'm gonna have to phone a friend on that one.
I believe so. I think it used to be like pregnant people, but I don't think anymore. But I'd look.
Because I know if you're not pregnant, it's a test of reinfection in 3 months. But I thought they still were recommending test to cure in a pregnant woman. We have an MFM on the call.
You can phone Janelle.
You guys know each other, right?
She's my co-resident.
Yeah, it's a test of cure in pregnancy only because in pregnancy you use azithromycin and that's not the preferred treatment for.
Right.
Okay. Gotcha. Thanks.
So you guys work together?
We were co-residents.
Man, everybody like knows each other. So that's completely awesome.
And embarrassing when you sound like an idiot.
You know, nobody sounds like an idiot. You guys wouldn't make it this far. You guys would not make it this far. I thought like the stuff you said was very, very good. I'm just going to go over it real quick here for everybody on the call. CDC has recommended a different treatment, for lack of a better word, for parental admission. But still, if you still say the tried and true, cefoxitin or cefotetan with doxily, you're supposed to add flagyl, it is still accepted. It's second line. But first line is exactly what Alexandria said, the ceftriaxone 1 gram IV every 24 hours, doxy IV or PO, flagyl IV or PO, 100 milligrams BID. For the doxy, the flagyl is 500 milligrams BID. The reason it could be IV or PO is the bioavailability of either of those drugs is the same IV or PO. So that's why it doesn't matter. And apparently doxy is very painful to infuse, and you could lose the line as well, from my understanding. HIV, correct. It is not an indication for delivery unless I guess the patient is extremely sick, right? So severe clinical illness, TOA, nausea and vomiting, pregnancy, no response to outpatient treatment. Also, if you think she has an acute abdomen, you think something else is going on, like you were saying, maybe like, I don't want to say an unstable patient, but somebody you need to like keep a closer eye on, so to speak, or evaluate well. In regards to outpatient management, I did not ask Alexandria this. If you, it is a 500 milligrams IM times 1 in addition to the same oral medications of the doxy and flagyl. If you weigh more than 300 pounds, it's 1 gram IM times 1. To my understanding, you keep the IUD in situ. If she does not respond, you remove it. And I think even if you have a TOA, which, and I read this just recently, that didn't sound right to me, but they said even with the TOA, if she responds, you keep it in place. That to me doesn't make sense, but that's what the CDC was saying. That's what I understood, what I read.
Okay, yeah,
Now, if the patient does not improve in the next 48 to 72 hours, then it has to be removed. And that's definitely per CDC recommendations, but it just scares me when you have a TOA and keeping that in place. I don't know.
so you said unless she doesn't improve, then you take it out?
Right, in 48 to 72 hours.
Okay.
Now, this is my personal opinion.
Uh-huh.
If you have a TOA, and everybody says, well, if the TOA is greater than 5 centimeters, 6 centimeters, you should be drained, da 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 da. Realistically, it's a pocket of pus. Maybe if it's 1 centimeter, hopefully that'll resolve on its own, 2 centimeters. But if there's a window, I would try and tap it. A lot of times this is my personal opinion, the radiologists say I can't tap it. But I've seen cases where the patient responds, there was a 5 centimeter TOA, she responds, she's sent home, and she'll come back two weeks later ruptured with pus all over her abdomen. And now she has to go to the operating room to clean her out.
Okay.
That's anecdotal, my experience.
Okay.
I don't know what the right answer is, but sometimes you take these patients to the operating room, it's just a mess. It's a complete mess. You can't tell one thing from another. Sometimes it's not that bad. You could do laparoscopically, you drain it, it's just all swollen, and you kind of drain it, you try and take out the wall of that abscess, but when it's really bad, I mean, I've seen like general surgeons almost remove like the colon thinking it was like part of the abscess, and it wasn't. And these are general surgeons who know what they're doing. So that shows like how bad the case can be. The tissue could get so affected. But that's my personal opinion. If I'm not mistaken, actinomyces is a gram-negative rod, and you're correct. The only time they recommend, this is the CDC, where I read just recently, if you have actinomyces cultured from an IUD, it has to be removed. You don't keep it in place.
Okay.
So I feel like that was an easy question for you.
I mean, I've studied it just because it's
Okay, cool.
like a generalist topic that I feel like I should
It's
know.
interesting because if you really think about it, this is my opinion as well. If you look at your office categories, it's very REI driven. Do you agree with that or not? Being an REI.
No, it was really hard to get all of my patients have infertility, so it was actually hard for me to like get enough people to.
But realistically, REIs nowadays, what you work on is infertility. But if you think, but what about galactorrhea? It's something that you guys used to do, right?
Yeah, but we don't
You
really
know?
do it anymore.
Yeah, you're making the big bucks trying to get everybody pregnant, but PCOS, right? That used to be an endocrine issue. Osteoporosis, that's an endocrine thing. Now, do you guys manage that? No. But you know what I'm saying? If you look at the topics, congenital adrenal hyperplasia, primary amenorrhea, precocious puberty, right?
Theoretically, yeah.
Theoretically, right? So, okay. But yeah. I mean, would have been better if I had asked you about IUDs.
I'm
sorry, it's out of my brain,
Yeah,
Would that be a better question?
Contraception's not my friend, so I don't know.
Okay, sorry. I could ask you next time. We'll get you on that. How's that? All right, but good job. Yeah, you have another question?
No.
All right, cool. I'm just going to see if anybody has any questions on the question box.
Okay, thank you. Have a good night.
All right. Thank you, you too. Appreciate it. Appreciate all your input, being an REI. So Janelle's saying, yes, pregnancy gets tested cure for chlamydia. Awesome. I saw somebody else. Did they put something else? Or does anybody have any other questions before I wrap everything up? Anything else? Anything anybody wants to bring up? Okay, here's a question. Hey, if Alexandria wants to get back on the call, it's a question from Christine. How soon do you recommend trying for pregnancy after chromoperturbation or endometrioma removal for highest success rate of fertility? Unfortunately, Alexandria has stepped out of the call. Darn gee willikers. I'm gonna be honest with you, I have no idea, Christine. I mean, at least 6 weeks, right? You want her to heal from her surgery. I have no idea. Is any other REIs on the call? I have no clue, to be honest with you. I'm just trying to see if anybody is an MFM. Nobody's responding. That's okay. Next time, just remind me when we're on next time. I don't know when I'm on next time. Maybe we can grab maybe Janelle can reach out to her. Okay, Jared's saying, I believe highest fertility after endometrioma removal is within 6 months. Well, I know for a fact if somebody had specifically endometriosis, I'm not quoting endometrioma, but endometriosis, the highest success of fertility is within the first year of the procedure, because they believe that endometriosis causes an inflammatory process in the peritoneum, and it makes it difficult sometimes for that egg to get to the fallopian tube. But I can't specifically say about chromoperturbation or an endometrioma. That I don't know. So thank you for your input there, Jared. Again, I'm not an MFM. Excuse me, REI. Trying to see here. Hold on. I'm trying to go to Janelle. I don't know if she's still on the call here. It says she's self-muted.
Yeah, I'm here.
You there? Hey, can you text Alexandria?
Text her.
Maybe she had to put her kids to bed or whatever. So I know we went over.
Is when should you try to conceive after endometrioma removal?
And chromoperturbation.
I messaged her, but
Yeah, she might be gone.
yeah.
Not for lack of trying.
Yeah.
Give her a couple more minutes. Anybody else have any other questions? What do you recommend, Janelle, being an MFM, about that case that they sectioned with the high blood pressure that did not have high blood pressure after they gave her medication?
Yeah,
And
I waited for steroid completion and delivered.
I mean, I don't understand. I remember I said, so what's the indication? Well, she has high blood pressure and she does meth. I'm like, oh, so drug use now is an indication not to wait till term delivery. Okay.
Yeah.
None of it makes sense to me anymore.
Alexandra said next. I'm just to clarify. Okay, yeah. So you skip 1 month and then try the next. So skip one cycle, then try the following cycle.
Okay, so in essence, you want her to heal.
Yeah.
So 4 to 6 weeks. All right. So hopefully that answers your question, Christine. All right, cool. All right. If anybody else has any other questions, I'm gonna stay on the line. You know, I could do a private chat if you need it. Also, if you have any recommendations how to improve the webinars, let us know. We try to stay current and make it interesting. Sometimes it's hard, but we try. So everybody can learn something on the call, so to speak. Janelle, thank you for reaching out to Alexandria, and thank you for your input as an MFM. Anything else you would recommend on that case? Oh, did I lose you? Is she offline now? No, I think she's offline. All right, cool. So I'll stay on the line, guys. Oh, okay. I have a question here. Okay, I want to go to you, Hannah. So in essence, Hannah has a specific question. So I'm just going to go and see if I can pick her brain, see if I can help her out. You guys can stay on the call if you have questions. You know, put them in the box, and hopefully everybody's questions are answered. I appreciate everybody who participated today. Everybody did a good job. I'm wishing good luck for people. I know we're winding down for the November exams coming up, so keep crunching and plugging along. So keep staying focused on the studies. So I wish everybody a good night and a good rest of the week. And I'm gonna see if I can help out Hannah. So I appreciate it. Thanks so much, and good night, guys. Okay, I'm going your direction, Hannah. Okay.
Can you hear me?
You there?
Yes, can you hear me?
Yes. So what's
Okay.
your concern?
Thank you so much. So
Yeah.
that is my primary mode of hysterectomy. I have one TLH simply because we could not reach her. We did not think we'd be able to reach her cuff for closure from below. And then I have one TBH, and then I have a couple TAHs. But I just wanted to verbalize sort of my thought process, which some of it is dictated by just how we do cases in our practice, and make sure that it sounds reasonable and that I sound like it's not just dictated by my practice, if that makes sense. So I guess like offline, I would say we generally operate in pairs. Usually the surgery person is operating with the provider who's on call. So there is a potential at any point that you would not have a skilled assistant to assist you with your case. So that is generally why we'll complete the case vaginally, because you can complete it with 2 scrub techs and wouldn't need any further assistance for cuff closure laparoscopically. And then additionally, I find that at least one portion of an indication or one complaint of a patient will be something along the lines of some pelvic pain. So assessing intra-abdominally I find to be helpful. And then additionally, I have a couple of patients where there was a known adnexal mass. And then also multiple of my patients have prior C-sections, and I feel more comfortable taking the bladder flap, or at least initiating the bladder flap laparoscopically than I do vaginally, especially if one of my partners was to be called away to an OB emergency. So those are sort of my portions of my thought process, but I just trying to sort of find a way to say that really succinctly.
Is there any specific case that has a very small uterus and you did an LAVH instead of a TVH?
Oh, good question. Let's see. Probably yes.
Because I can look at your list too. Let's see.
I have 21, 22, and 23 are all LABHs, but none of them are less than 100 grams. Yeah, those are 19 and 20 are also almost 200 grams.
I mean, because you make it sound like it's a bad thing that you did an LAVH, and to me it's not. I mean, you got a lady here with a BMI of 49, and it says minimal uterine descent on exam right there. it's sufficient to have done an LAVH.
Okay.
You know what I'm saying?
Yeah.
I mean, a 200-gram uterus, that's big for some people to take out vaginally. Some people can, don't get
Okay.
me wrong. Some people are just masters vaginally. I mean, she had a 5-centimeter fundal that wouldn't be in the way of like the uterines. What was
Case
the
3,
size?
the
What
one,
was the what was the size of the uterus in case 19?
oh, let's see. Oh, did I leave it out?
Like just the like your hand, like you did a how many week size uterus?
I'd have to go back and let me read over it
Because
to
maybe
remember
maybe
who
it's
the
a
patient was.
12-week size uterus. Some people would feel uncomfortable doing that vaginal. So you start out, you do a laparoscopic start, and then you complete through the bottom.
Oh, so case 19,
Yeah.
she had
Yeah.
a single dominant fibroid, that 5-centimeter fibroid. It was, fundal subserosal.
Yeah.
So it was not contributing to
Right.
any like significant width of the uterus. The uterus was very mobile. She had
I mean, it's not like you had a
she was
50-gram
nulliparous.
uterus.
Yeah.
Okay, so you wanted some more descent. Okay, cool, awesome.
Mhm.
It isn't like you have a 50-gram uterus you took out robotically.
Okay.
You see what
I
I'm
have,
saying?
yeah, I think the smallest of them that I unfortunately had to open, case 3, she started as an LAVH. She'd had a prior endometrial ablation. Looking at her pelvis, she had endometriosis and her entire posterior cul-de-sac was obliterated, and we just could not enter posteriorly, and tried, because we were laparoscopic, we're able to look from above and below and see if there was a safe place for a colpotomy, but there just
So
was
right there,
not.
you
So
would
we had
never
to
have been
remove.
you never would have been able to do this case vaginally,
Yeah.
right?
Yeah.
And you have your complication there, so I don't see anybody knocking you for that.
Okay. I think I probably talked about these cases mostly with a Urogyne from residency, and she was like, "Why so many LAVHs?" And so I was like, "Okay, I need a clear answer on why I chose LAVH instead of TVH for the majority of them."
I'm just looking.
Like the 35-gram uterus on case 6 was a TVH.
Awesome. So why case 5 was not done as a TVH?
Case.
She had surgery before. She had lysis of adhesions.
Yes, she
Yeah, you
had
should have put that in
prior
your
C-sections.
yeah, you should have put that in your diagnostic, because then there wouldn't be that question. Then
Okay.
why case 4?
Case 4, she, let's see. Oh, because she had, she's, not that you couldn't do a BSO from below, but she strongly desired a BSO. She was undergoing treatment
It'd be different if
for
it was a
breast cancer.
risk-reducing procedure. It's different if she was a risk-reducing procedure, because that you definitely should do laparoscopically.
Yeah, so she did not have a BRCA diagnosis. She
Okay, because you
had
need to do
prior
pelvic
diagnosis of
washings
breast
and all that
cancer.
stuff.
Yeah, no, she, I had discussed this case with her oncologist, and let's see. Yeah, so she did desire a BSO, definitively discussed with her oncologist, and she had estrogen receptor breast cancer. And
yeah, that's sometimes
was
recommended in order to decrease her recurrence.
Yeah, they had said that it was no strong recommendation, like given that she was at the average age of menopause at 51, that they didn't feel that a strong recommendation. They said they'd feel more strongly if she was into her 50s or 60s. They said you would just make the diagnosis based on your clinical suspicion for any issues, and then shared decision making with the patient. And she requested a BSO.
That's what she elected. Yeah, I can't fault her. Case 21, you have a 4-centimeter cyst, so scope. Why case 22?
Case 22, she do not have a strong indication from like a preoperative workup standpoint for her
I mean, I'm gonna be
for an
honest, I don't
LVH
think it's
over a
bad.
TBH.
I don't think it's bad. So I don't know why your Urogyne attending had said that.
Okay. I just
What
thought that
about
I'd
case
get some other
23?
input for case 23.
Mm-hmm.
Yeah, again, no strong indication other than that's just
Okay.
my preferred
Your
and what I
preferred.
feel most comfortable with. She had C-sections, that
And
patient.
I know people give that as an answer as well.
Okay.
You know, so case 26, you have 2 C-sections in her history.
And she had the cyst as well.
Okay. Then you have hematoma, post-ablative syndrome. This is case 39, 146 grams.
Yes.
Again, I don't think there's anything wrong by saying, you know, I feel more comfortable doing that.
Okay. Yeah, that patient presented with significant pelvic pain. She was actually like a follow-up from the ER to our office. So definitely high suspicion for the post-ablation syndrome as the source of her pain. But I think I hope if they ask about it, I would say wanted to evaluate for other potential causes of pelvic pain at the
Yeah,
time of
nothing
her
wrong with that.
surgery. Okay.
But then you're going into the weeds now. You know what I'm saying? I mean, can they bring that up? Yeah.
Okay.
You know,
I just wanted
but
to get some other input
it,
from someone that
it's
doesn't do
like
TBHs all day long. So thank you.
I'll ask if it's, I see all these TLHs and I don't see a TBH anywhere. You know
Okay.
what I'm saying?
Mm-hmm.
Because most mode of route of hysterectomy now is either robotic or TLH. Not that many people do LAVHs.
Mm-hmm.
I don't know if you know.
I feel,
I don't know if you've noticed that with some of the cases that we present on the lists and stuff. It's all TLHs or robotic.
yeah, I find that personally, I am happy that that's like a part of our practice because I feel like you just feel really comfortable from entering above or below, whatever the pathology is, whatever is giving you trouble with your anterior exposure. You just feel like you could approach from both sides, which I feel like is really nice because I'm
Right.
not afraid of losing either skill set, which I appreciate.
I'm gonna be honest with you. I don't see anything wrong. Could I be wrong?
Okay, thank you.
I don't know why your urogynecologist, but then of course some people they want to find fault to kind of scare you a little bit.
Mm-hmm.
You know what I'm saying? To give you that, what they say, the burn at the hot seat. So I don't see
Yeah.
anything wrong. Yeah, you have your explanation for those little bit of those particular cases. She has she had a mass, she had pelvic pain, whatever the case may be. And then if they pick, well, I don't know, under this case, why this case? And I go, well, luckily I work in a facility that we work as a well-oiled machine. The entire OR staff feels very comfortable in setting up for an LAVH, and that's our preferred method. I don't see
Okay.
anything wrong with that.
Great. Thank you so much for your time. Appreciate it.
I probably would not even thought twice till you brought it up. But again, everybody sees a case list differently.
Mm-hmm. Yeah.
You know what I'm saying?
Okay.
And you are
Yes,
doing a minimally
absolutely.
invasive case for the patient. It's not like you opened up the patient in every case. I'm talking about like a TAH.
Mm-hmm.
There you're gonna have to defend some stuff,
Mm-hmm. So LAVH is going to be
That
seen as
helps.
equivocal to TLH in terms of minimally invasive approach.
In my mind, it is.
Okay.
But that's the way I trained, and I like LAVHs. I don't like TLHs, but that's my personal opinion.
I feel like most of my partners fall into that camp as well.
Because nobody really does anything with vault suspension or anything like that. They say they go to the angle and they go through the uterosacral, but really, is that really going to help the patient? No, you should do a modified McCall or a McCall, uterosacral ligament suspension, whatever the case may be, because that's really appropriate for the patients, but we don't do that anymore. And the same thing with, how do you identify the ureter? Do you really identify the ureter in a TLH? No, you don't. You just do a cystoscopy at the end of the case,
Right.
you know? And that's just the way I saw something in the pelvic sidewall and it was peristalsis and it looked okay, you know? When you do the
Yeah.
abdominal hysterectomy, we used to, go into the broad ligament, we would identify it and we make, but that's the way, you did it in the old days, so to speak.
Mm-hmm.
If that makes any sense.
Yes, it does. Thank you so much. I really appreciate you staying after. Really appreciate it.
No worries. Okay, you take care and
Take care.
good luck. I'm not concerned. Could I be wrong? Yeah, I could be wrong, but I think it looks good.
Okay, thanks again. Have a good
All
night.
righty. Yeah, no worries. Right. Good night.